Okay, so I'm going to talk to you today about mistakes in neuroradiology. First thing is, why am I giving you this talk? Well, there was no one else to do it. When you organise conferences, it's pretty hard to get people, as some of you who do that know. I'm 57 years old. I actually thought I was 56 until I did this talk. So I found out I was 57. It kind of depressed me. And I report 7 days a week. Now, I don't say that to show off and say how great I am. You probably think I'm an idiot. But the reason why I say that is all it means is that I make more mistakes than most people. I have 3 different employers, so that means the mistakes are pointed out by more people than most. And I'm told that my IQ is low by the registrars, but my EQ is marginally better. So it's an improved emotional versus IQ ratio, which is maybe something important when you're dealing with mistakes. We've heard the aphorisms, everyone makes mistakes. They're almost cliches. And if you're not making mistakes, you're not working hard enough. There are other aphorisms as well. Some people make more mistakes than others, and some people learn so well from them, they make the same mistake again. My father used to say to me, actually, he used to say to us, you learn so well, you make the same mistake again. I always thought he was talking about my sisters. He's 94 now, and for the past 60 years, he said he was talking about me. But there you go. And there are mistakes, and there are mistakes. And sometimes mistakes are contextualized. Like, for example, unfortunately, I missed a fracture in somebody's foot who happened to be an elite athlete. And in that kind of setting, in that kind of group, in that kind of practice, that was like missing an aortic dissection or an epidural abscess or a basilar artery thrombosis. So context sometimes makes the difference as well. Now, what's your attitude if you make a mistake? Do you take it badly? I know I do. Do you try and blanket? I've told people about their errors, and others have as well. And, they just go, oh, well. One person said to me, that's why I have insurance. Actually, a few have said that to me. That's in my miss rate. It's like one person who reports a lot said, look, I report so much that, that's acceptable. Do you take it differently if it's in your area of expertise versus whether it's not? Do you think about the patient, or is it all about yourself? And sometimes it depends who points it out. Like if it's a complete stranger, you might not feel so bad as if it's pointed out by a colleague, for example, who you work with all the time. And this is quite a bizarre kind of question. People think, obviously this is a bit of a controversial talk. If there's any complaints, just email the organizer of this conference. I'm sure you'll get a good response. But this is a bit controversial. Should you tell a person if they make a mistake? Like, I know some radiologists who are top class, work really hard, make almost no mistakes. And if you tell them, if you point out a mistake to them, you can absolutely crush them. You can crush their productivity. I've seen it. And you ask yourself, well, should you tell that person, have they made a mistake? Everyone says, yeah, if I want to know if I'm making mistakes or not, but I wonder how many of us really, really want to know. And so somebody once said this to me, that they said, oh, I don't tell certain people if they make a mistake. Some people also get very defensive. And then you think, well, what was the point of even telling them? And, again, we all want to hear about our mistakes, but I'm not sure if we really do. And then there's another subject that when I was a registrar, we didn't even talk about. I'd never even heard of, oh, they report a lot of cases, or they don't report as many cases. But speed now has assumed a huge importance. Radiologists are rated on their productivity. You ask a manager from a corporate practice, oh, what's so-and-so like? Oh, they get through a lot of work. What's their accuracy? Oh, well, it doesn't matter. But it really has shot to prominence the idea of speed. The registrars talk about it now as well as the consultants. And one could argue that the aim of most radiology learning is to learn well so that you can get through cases faster. But of course, we know there's always a trade-off. This is from a guy named Chris Agton, who's kind of talked about this in this book. I've got no interest in this book, no financial interest anyway. And he actually has written a book, How to Report More Studies Faster. And he has this graph in it. He shows accuracy and speed, and you want to be at the sweet spot where your accuracy stays the same, you've sped up, and even with increasing speed. So that's about where you want to be. But it is an interesting concept. How do you maintain, this is just my opinion, how do you maintain a good standard? In other words, avoid mistakes? Well, obviously, you learn from colleagues. You read review articles. I personally don't look at many studies in journals. you know, as you get older, you kind of think, oh, that doesn't really fit with my experience. I don't know if I believe that, but certainly the images are very worthwhile. You do conferences, workshops. I do case quizzes personally, Radiopedia, StatDX, and multidisciplinary meetings are very important as well. You see all the great cases there. Look, I know that some people don't work in hospitals. You can still get access. You can still, well, try and get access to these multidisciplinary meetings. Sometimes they're recorded as well so that you can actually see what's going on. Peer review, of course, is very important. Even social media, there's some people on X or Twitter, whatever you want to call it, who put some great stuff on there. I personally think one of my favorites is database mining. And that's where, you know, if you work at a hospital, for example, and you have a lot of cases where you can search the database, like let's just say I wanted to see cryptococcal infection. I searched our database, many cases. It's different to the internet because on database mining, you get to see how did they originally present? What kind of differentials? What did they miss? What didn't they miss? And you see the progress of the study rather than more static cases on the internet. Structured reporting is said to reduce it because, you know, you don't miss structures because you go, you know, A, B, C, D. I personally hate structured reporting. I think it's like telling an artist to paint by numbers. And of course, with structured reporting is voice recognition. That's where you get the cheapest person in the department, the typist, and sack them and make the radiologist the typist, who's the most expensive person in the department. But that's another issue altogether. There's also artificial intelligence as well. And if you want to avoid making mistakes, make a big mistake. And there was an old joke that used to go around when I was a kid, and they used to say, how do you remember your wife's birthday? And they said, just by forgetting it once, or in my case, forgetting it twice. All right, so how do you measure your standard or your improvement? How do you know how you're traveling? Well, I personally like to do a lot of case quizzes to see how I stand, quizzes from the literature. Other people would say, oh, well, you know you're doing all right because you haven't made any complaints against you. You know, there are people who think that because they haven't had any bad feedback, that means they're not making mistakes. And I would be very wary of that. But there are other ways of measuring whether you're improving or not. So what are we going to talk about? I want to show you some cases, obviously. Look, what's next? Look, I don't know about all this omission, commission, confirmation bias, all this kind of data that you see all written here. I just want to get down and dirty and talk about some cases. So the cases I'm going to show are cases that have been missed or misinterpreted with adverse outcomes, and most are regular occurrences, like this next one. So this was an 83-year-old sold by ED to us as acute confusional state, and only the CT non-contrast was performed and it was reported as normal. So I just want you to have a look at that. Take 30 seconds to have a look. There is an abnormality. There's a marked abnormality on this scan. And in fact, it's interesting. When the clinician came down to review the case, he said, I want to look at that case again. And we said, the normal one with the acute confusional state. And he said, that person's not acutely confused. They're locked in. And of course, when you look at it, they have a basilar artery thrombosis. This patient went straight to clot retrieval. And that's a basilar artery thrombosis that's not to be missed. Okay, here's another one here. Here's another basilar artery thrombosis. I'll talk to you more about this at the stroke talks. This is a 52-year-old male, severe headache, unconscious collapse, right-sided hemiparesis and nystagmus. They did the perfusion in the upper part of the brain, which was normal, kind of misled the radiologist, and that patient has a basilar artery thrombosis and that patient died. This is an area that's really amenable to clot retrieval. You do not want to stuff this up. And every year, in every hospital, this happens where somebody misses a basilar artery thrombosis, and it's traumatic for the patient and it's traumatic for the radiologist as well. So I want to ask you a question. What does basilar artery thrombosis, spinal epidural abscess, and thoracic aortic dissection have in common? Well, what they have in common is this, that if you miss it, people do badly, and they do badly quickly. And even if it's picked up later on, it's very difficult to retrieve. It's usually difficult to retrieve the situation. It's been discussed in the literature multiple times. Always look for it first. This is just my opinion. You don't have to listen to me, but I always look for it first on a CT angiogram. Now, I know there are people who are doing CT angiograms in and outside of acute stroke, but this is something that I always look for. I don't care what the history is. I don't care what the perfusion shows. I don't care what the perfusion targets. I don't care what the CTA shows elsewhere. I always look for that structure first. And if you've ever been burned by one of these, there's nothing more sobering than a miss in this area. Another patient, 39-year-old man, was hospitalized with a severe headache of sudden onset. He was experiencing this complaint for the first time. Had a non-contrast CT. Does anyone see the abnormality? It's a bit subtle. It's got by a couple of the registrars. They've all been tried out, these cases. Yep. 1 day later, this is what the scan looked like. Mind you, the patient was sent home, and that was 1 day later when they represented. They have an ACOM aneurysm rupture. When you go back, there is a vascular abnormality on the scan. Here's another patient following the same theme. 60-year-old nausea and vomiting, new onset of absence seizures, question mark mass. This was picked up by one of our registrars, very good pick. And you can see here there's an abnormality. Again, as we go back, that's it there. There's a basilar artery aneurysm, basilar tip aneurysm, and that patient went to treatment as well. So it's an important point to make that you shouldn't miss a vascular abnormality on non-contrast CT, because every now and again they can be relevant. Here's another theme, 70-year-old post-endovascular clot retrieval stent of the left internal carotid artery, successful, question mark hemorrhagic transformation. And this is the scan here. Just look at what is obvious here, and that's these dense foci in the periphery. Hounsfield unit of 400. It was reported, wasn't even reported, it was just called a normal brain. Now, I'm not trying to be holier than thou here. I don't blame people calling it normal. Maybe they saw it and just brushed it off. That's what it looks like on the SWE imaging, foci of susceptibility. But what was bizarre was 1 day before, they weren't there. 1 day before the intervention, they weren't there. And 8 months later, one appears there, where that one that was there before has probably migrated and the other one is still there. So you've got these kind of weird things. What's the diagnosis? These are calcified emboli. I actually, when I came to Monash 10 years ago, I'd never heard of these, and then it was pointed out to me. They are a do not miss imaging diagnosis. They're not as uncommon as you would think. In the conclusion of their article, they wrote, calcified cerebral emboli are more common than previously assumed, are frequently overlooked or misinterpreted, affect clinical course when diagnosed, and carry substantial risk for recurrent stroke. The bottom line is, if you haven't reported this, you've missed this, and it's not good to miss. Here's some other examples. They're not that uncommon. A couple of calcified emboli there associated with some infarction. And here's one you can see. Here's another calcified embolus there, probably a few here, and one sitting in the vessel there. So they are not uncommon, and you don't want to be missing them. 78-year-old with ataxia. This is actually something that is very common. So what's the abnormality here? It's not in the parenchyma. Yeah, so if you look here, correct. So on a spin echo image, you should always have a dark or black signal in the vessels. So here, the right vertebral artery, the intradural portion, the V4 portion looks fine, but on the left, it doesn't look right, okay? The signal should be black, and this is like gray. This was missed. And unfortunately, not every patient who comes through is going to get an MR angiogram. So you go, oh, I don't care. It doesn't matter if I missed it. I'll see it on the MR angiogram, because not everyone gets one. And the patient represented 5 weeks later. I won't show you the infarction, but they had a large cerebellar infarction which had developed, which may have been treatable previously with a bit of anticoagulation or something if they saw that. Here, they did have an MRA, and that confirmed the abnormality, the absent vessel there. And you can sometimes see thrombus in vessels or calcifications in vessels on the SWE imaging as well. So it's something that you don't want to miss, the flow voids. It's really something that happens again and again and again. Even if they haven't had an MR angiogram, one of your routine areas to check on an MR brain is you always have to check the flow voids. So here's a case here. This was actually a T2 FATSAT, but it doesn't matter. Do you all see the abnormality? Well, that's how the vessel should look. A basilar artery there. This is how, look at the ICAs. There's occlusion or high-grade stenosis of both internal carotid arteries there, which was missed. right? They hadn't had an MR angiogram, it was missed. So absence of flow voids are frequently missed. You don't always have the MR angiogram, and they can be a harbinger of stroke. Here's another companion case. It just shows a clot in the left posterior cerebral artery, just showing you again how SWE can show vascular clot. This is an interesting case. This kind of case comes through every, I don't know, 18 months, 12 to 18 months. It's a 78-year-old with left-sided weakness, query stroke. This is the MR angiogram. Okay, it's a little bit bizarre here that you obviously don't see the flow-related enhancement in the left vertebral artery, but it is a funny kind of absence of flow there. Usually that distribution is a little bit unusual, but that's fine. It might, you might think it's a little bit weird. You do the source imaging, right? There's no flow in that left vertebral artery. So it was reported as occlusion of the left vertebral artery, but just as a tip, if ever you see these kind of things, always go back. You should train your eye anyway, but always go back to the conventional spin echo imaging. And what do we see on the spin echo imaging? Well, both vertebral arteries are there. They're there. They're nice. They're clean. They look good. So how do you explain that you can't see the vertebral artery on the MR angiogram, but you can see the vertebral arteries normally on the T2 imaging? So what's the diagnosis? That's correct. And an ultrasound was done as well, and it showed retrograde flow on the left vertebral artery. And as you said, that's a subclavian steal syndrome. So unfortunately, as luck would have it, the writing is over the stenosis, but there you have the right subclavian. I couldn't get rid of that. Couldn't believe it. But that's the right subclavian, and it's occluded at that point there. And you can see the left vertebral artery is completely patent throughout its course. And the reason why it happens is that saturation bands to block the venous contamination that we do for the MR angiogram also block the reverse flow in the vertebral artery, and that's why we don't see it. But you don't want to mess that diagnosis up. Some of the more common scenarios that we sometimes miss are 3 days post severe headache. What do you think? Anything? So one of the things, look at this right sylvian fissure, nicely seen on one side, and the left sylvian fissure you can't see, and the sulci on that side are effaced, right? They're partially effaced, and you may even get the impression of some hyperdensity there, but that's a bit rough. But certainly that on the left side there looks to be some unilateral cerebral edema that was secondary to an aneurysm, which was missed. So you really got to train your eyes. Obviously, windowing as well might help. Here's a companion case. If you want to know what anisocoria is, I had to look it up. It means unequal pupils. A patient was found in an unconscious state. Here's the CT brain. This one's a bit more subtle and difficult, I think, but this patient has a colloid cyst. Don't worry about that. Oddly enough, they didn't mention it, so they missed it as well in their presentation, which I thought was a bit bizarre. Don't worry about that either. Is there anything else that kind of grabs your eye? It's going back to the same theme as the previous case. Yeah, so the sylvian fissure there looks good, less well demonstrated of the left sylvian fissure, and also you can see the sulci here are slightly more prominent on the right than the left, and there's probably ill definition of the grey-white matter on the left side, and even the basal ganglia looks a little bit blurred there. So they're signs of early infarction. Fortunately, that's the follow-up scan. And obviously, you would use windowing and that kind of thing to help you. But, these things are missed, unfortunately. 70-year-old with unconscious collapse. Another one, another miss. Okay. Anyone want to venture on this one? Again, you're training your eye. You're trying to look at that grey-white matter differentiation. You can see here that in the occipital lobe territories bilaterally, there's complete loss of the grey-white matter differentiation. And this actually was a basilar artery thrombosis that was missed as well and infarcted. Always beware of loss of consciousness and unconscious collapse, particularly in the basilar artery thrombosis setting. All this kind of consciousness always can relate to that. Here's an interesting case that, again, was also missed. This is an axial flare. It was missed on it was misinterpreted and missed, right? So on the flare imaging, you can see in the subarachnoid space, there's hyperintensity, but it's like, because the way we've imaged, it's going through the sylvian fissure there. You can see that hyperintensity, a bit less there. And there you can see that hyperintensity there. And also You can see some hyperintensity there. So this is subarachnoid flare hyperintensity. This raises two things. One is this one was missed. And another thing that I've heard people say to me again and again, oh, I've got a patient, they've got subarachnoid flare hyperintensity. It can't be hemorrhage. I said, why not? Because it's negative on the SWE and it's negative on the T1. Can't see anything. Well, just a word of warning that the only feature in acute subarachnoid hemorrhage may just be on the flare imaging. So don't let that put you off the diagnosis of subarachnoid hemorrhage. It's very important because I've heard that again and again. This patient actually had 3 aneurysms as well, but still the subarachnoid hemorrhage got missed and there was a bad outcome. This is an ARP Mini. If you haven't seen this before, it's good. If you have, that's good. It's an ellipsoid hematoma. You don't often see hematomas like this, but it's quite ellipsoid in nature. It's centered in the Sylvian fissure, and it's almost an ARP Mini for a right MCA aneurysm. Here's another one. Unusual place to get a hematoma. Here it is here, blood layering the corpus callosum, and that was due to a ruptured pericallosal artery aneurysm. But I do want to just make a point for example, at Monash Health, we have very low threshold for performing a CT angiogram for any intracranial hematoma. I personally, I don't care if it looks hypertensive or not, I'll still do a CT angiogram because I know that in a small but certain number of cases that it's not due to hypertension, it can be due to something else. So basically all hematomas, virtually all, will get a CT angiogram, and the techs have been trained to do that as well. This case, 65-year-old, fell from a ladder, subarachnoid hemorrhage, extraaxial hematoma, reported as, secondary to trauma, all good. But there was just a little bit of an issue because when they went back to the history, the gentleman was on the ladder, said to his wife, he cried out to his wife, look, I've got a really bad headache, and then fell off the ladder. So in fact, what this was an aneurysm rupture causing the subarachnoid hemorrhage, and this was the trauma. So just be a little bit circumspect in trauma. We've had multiple cases like this. This one is from the literature. This one was considered, this patient had an MVA and took a little bit of a head knock, had a bit of what looked like hemorrhage there in the right temporal lobe. That was reported as a contusion. But in fact, when they went through the history and all, they felt it just didn't fit. And in fact, he had a GBM then instead. So again, just be a bit circumspect. Okay, another patient, 50-year-old doctor, vertigo and dizziness, past history of mitral valve repair. The CT was NAD, the MRI showed the only abnormality was found in the gradient echo sequence. They didn't have a susceptibility weighted image at this study on this patient. Now, before you say anything bad about this, this is my brain, so take it a bit easy. You can see that I've got these little black dots in my brain after I was scanned, and I thought, I came off the table and I thought, geez, I don't know what's going on here. I started to smack my head a bit to see if I was all right, and all it did was make my vertigo worse. And I thought, what's going on here? Do I have a bit of amyloid? Doesn't make sense. Amyloid should spare the cerebellum. Anyway, I didn't think, and I rang someone up to take a look at it, and they said, oh, it's that. And I said, oh, yeah, I forgot. I didn't realize that. So we'll just go through it. So some of the differentials you might want to think about: microbleeds, cavernomas. I didn't have any trauma. Is there anything else you might want to think about? This is a presumptive diagnosis. No. The CT was negative as well. The intracranial metal emboli. There was a history of cardiac procedure. In my case, I had mitral valve repair. It's a presumptive diagnosis, of course, but it's come up in the literature in multiple times. Multiple new rounded foci, variable in size. They say you get target-like lesions. I'll show you a companion case. This is from the AJNR, 73-year-old woman, open mitral and tricuspid valve repair and closure of the left atrial appendage. Now, this was the study done one day before the SWE is clean. The day after the study, there are these foci of susceptibility. One of them shows this so-called target sign. It's a presumptive diagnosis. Remember, why we can't see them on CT, it could be due to their tiny size and their marked ferromagnetism, but it is something to always think about. We've had a few through Monash where we've said that's a presumptive diagnosis. This is another one that got misdiagnosed. 35-year-old sudden headache. You'll see here on the axial T1 all these hyperintensities on the in the subarachnoid space, and also there's something in the tip of the right lateral ventricle. On the SWE study, you know, the blood sensitive study. Oh, look, there's all this susceptibility as well. No problem, subarachnoid hemorrhage, move on. However, when you look at the post-GAD axial T1 with fat saturation, this all suppresses out. So in fact, this is not subarachnoid hemorrhage, this is a ruptured dermoid. Okay, I've seen that a few times where it's been misdiagnosed because you haven't thought about the signal. And you say to me, but hang on a tick, ruptured, why is the signal low on SWE imaging if it's fat? Because we also suppress out the fat on SWE imaging as well. So it's something to just to remember. And here it is actually, they managed to get the CT and you can see the CT shows fat, so that makes it easier. Just a quick reminder on SWE imaging, not everything that is dark is calcium or blood, and fat can look dark on SWE. Here's another patient, T1 hyperintensities. What's the differential for T1 hyperintensity? Extraaxial space. Well, you'd probably think this patient, one of the things is hemorrhage. You'd probably think these are subdural hematomas, which would not be unreasonable. On the SWE as well, look at the SWE, it looks all dark. You'd think, oh yeah, it's all blood product, but in fact, this is not blood. When you're on the CT, it shows ossification. Ossification contains fat, and so it's not surprising that it's also bright on T1 and also can be low signal on SWE. Now, I know some people don't do MR, so I don't want to labor the point, but I do want to be just bring this up because this error happens every now and again as well. On SWE imaging, you have this, look at this case, you have T1 hyperintensity here. So you say, oh, probably blood, which is not unreasonable. But then you say, oh, if it's blood, how can it be bright, so bright on SWE imaging? It doesn't make sense. And then it gets talked about as an alternate diagnosis, like for example, proteinaceous fluid or something. But there is a thing, the same as we talk about a T2 shine through, there is a T1 shine through effect on susceptibility weighted imaging, where the T1 is so bright it overcomes the SWE effect. And it definitely is an under-recognized phenomenon. All right. Okay, so just a couple of concepts here. Let's just say there is no history here and you're looking at this and you consider on imaging alone, it's a FLAIR image that shows confluent T2 FLAIR hyperintensity in that frontal pole of the left temporal lobe involving both the anterior hippocampus and also the lateral aspect, and here on the right frontal side as well. Now, the patient had a history, in fact, I've said no history, but the patient had a history of trauma. Again, here's another case, and it was called post-traumatic. But when you think about it, trauma is okay for the lateral aspect of the frontal pole of the temporal lobe. That's a classic, but it should never really, you don't really see trauma involving the medial aspect here of the temporal lobe. So you should think about an alternate diagnosis. The other thing is the crossing of, could it be ischemic? Well, we talk about the crossing of vascular territories. We know that's the MCA territory. We know that's the PCA territory. So the crossing of vascular territories, it doesn't mean it can't be ischemic, but it does lead you to think as an alternate diagnosis. Certainly when I was a registrar, they always showed the CT brain where they had a low density like this, and you'd say, oh, it's an infarct, and they say, but it's crossing vascular territory. So it was in fact herpes simplex encephalitis. This case actually was autoimmune encephalitis, but that doesn't matter. It's just trying to make a point. Here's one. I've put this in because every textbook I've seen that talks about mistakes in neuroradiology, they love this case. I don't know, and we've had a few through Monash as well, and Imaging Associates. Code stroke, question mark, left infarct, history of right facial droop, leaning to right, now having seizures. They did a CT perfusion and a non-contrast brain as part of that. And I just draw you to the non-contrast brain for a start. It's a little bit subtle, but there's this area of hyperdensity within the right basal ganglia. It's very sharply defined. You might be inclined to say, well, it was reported as a right basal ganglia hematoma. I suppose if it was a hematoma, firstly, it's sharply defined, and secondly, you can see all these little ditzels of almost brain, through it, which is a bit unusual for a hematoma. It should be more bland and whiten out that area. So the question is, what would you, hyperdensity in the right basal ganglia, that's what it looked like, sorry, on the MR, T1 hyperintensity, very clean looking. What question should you ask next? It's kind of like an exam, I suppose. Well, the question you want to know is what's their blood sugar level, because this is a classic non-ketotic hyperglycemic manifestation, usually manifests as hemichorea and hemibolismus, but it didn't do so in this patient's case. But it's just something that pops up every now and again. Okay, I'm going to finish on this area here. As you know, during the COVID debacle, people were being vaccinated with AstraZeneca, and AstraZeneca had a risk of having venous sinus thrombosis. And we were doing loads of CT venograms, like it just went, off the charts. And in fact, that's kind of kept up now. We've started to do a lot more. I don't know about you guys, but we do a lot more CT venograms and MR venograms, I suppose, as well. So this person actually, interestingly, had what they said, a proven thrombus in the leg, a DVT secondary to the AstraZeneca vaccine. So then he developed a headache and he went along for an MRV, and this was the non-contrast MRV. And here it is here. You can see that there's paucity of what looks like flow in the right transverse sinus, right sigmoid sinus, right internal jugular vein. There might be some hyperintensity in the on the sagittal T1. The axial flare didn't show much. And this was slam dunked as a venous sinus thrombosis, which in fact is a pretty strong call. I mean, this person was going to have to go on much longer anticoagulant therapy. Slam dunked, no doubt. Anyway, a friend of the family, I tried to persuade them to have a contrast test because, we've all seen this before. I'll show you in a minute, but he was very by the book. Anyway, 2 weeks later, had the test, and 2 days later, actually, they did have 2 days later. And the CT venogram, this is just the post-contrast brain, but it shows of the CT venogram, but it shows that it was completely patent. So be very wary about calling thrombosis on a non-contrast MRV. Be very, very wary of that. I've seen that again and again. It's just not such a great study. Bring back, if you're not sure, just bring back for a post-contrast MRV. I rarely do non-contrast MRV or offer a CT venogram, which is a great test. And as I said, CT venograms and MRVs have dramatically increased in requests during and post-COVID. So this is an exam case, single image. What's the diagnosis? Pretty tough. I wouldn't want to, I'm glad I'm not sitting this one. So you'll notice here, you've got this confluent area of white matter T2 hyperintensity. It's probably an axial T2 fat set, but white matter hyperintensity, but there's something else on this scan as well. Does anyone see it? There, so you remember you should just have a normal black appearance in the sinuses. There's a clot there, so that's a venous infarction secondary to thrombosis. And it's just something to be aware that you can have venous infarction where you may not have obvious blood, and also always check the sinuses as a routine as well. I put this list because I carry in my phone, I don't know if you guys do, I just have lists and I put them in the notes section of the Apple. Apple has notes. And I know this is not in any particular order, but when you're doing MR and you're getting all crazy cases, I like to just have a long list to know what I'm going through. I'm not saying it's in the order. I know registrars always have to have an order of incidents, but I think it's something good that you can just make lists for yourself and you can just go straight to your phone if you're in doubt. All right, here's another case, another exam case, similar theme. All right, what's the diagnosis? Yeah, that's right. So you can see this patient has a convexity subarachnoid hemorrhage, and that's right. And you always check the sinuses as a routine as well. So that was, and you can see this is a non-contrast study. Look at that for clot in the superior sagittal sinus. So this is quite an interesting thing. We see this every now and again, this isolated convexity subarachnoid hemorrhage. In order of frequency, trauma, amyloid, RCVS or reversible constrictive RCVS, central venous thrombosis, and some other causes as well. But it is a condition we see every now and again. I would say for us in our department, we would see amyloid and RCVS as a cause. Interestingly, it seemed to be a bit more prevalent a few years ago. It sort of died off a bit, but it's something you need to be aware of. And just remember this, that you can have an effect, you can have a venous infarct away from the site, or it doesn't have to be adjacent to the site of the venous sinus thrombosis. So just make sure that if you think someone's got a venous infarct, or you can have the thrombosis quite well away from the site. Don't call a hypoplastic vessel, if there's a symmetric bony groove, don't call a hypoplastic vessel of the transversal sigmoid sinus in a setting where you see a big bony groove. And just remember, there is a normal variation in anterior extension of the supraesophageal sinus. It can occasionally terminate anyway. This is a normal study and can occasionally terminate anteriorly. Seen this a few times. Patient has a CT angiogram as part of a, let's just say a CT, well, it's usually part of a CT perfusion stroke workup. And this was reported as venous sinus thrombosis, right? Not an unreasonable thing to say, but what we do for our CT, and I'll talk about this tomorrow or Sunday, or no, tomorrow is Sunday. I'll talk about it tomorrow, but you can see here, we always do a post-contrast CT brain as part of our workup, and you can see here that it completely fills out. So just be careful about these diagnoses because it's a big diagnosis to make, venous sinus thrombosis, and you can get differential flow. And because you're doing it as an angiogram phase, you have to be careful as well. So I'm going to finish there. I want to acknowledge all the colleagues I've worked with because they've pointed out all my mistakes, and we've collected a few cases. I mean, I've got loads more cases, but I think we should probably stop. And I was just saying, just be careful out there. Thank you very much.